as part of our Hilton Humanitarian Prize Symposium, we always think it's important not only to celebrate the prize recipients, but also to learn something from their experience, perhaps to benefit your own organizations. So we've arranged a discussion that we're calling today the South's Role in Achieving Global Health Goals. Just one technical note about this panel. Unfortunately, the Honorable Zahid Malek, the State Minister of the Health and Family Welfare Ministry of the People's Republic of Bangladesh, whom you see in your program, is unable to join us today. I'm going to introduce our panelists first, as I did previously, and then we'll have a discussion. And all of us realize that we are the last thing between now and your enjoyment of the reception this afternoon, so we'll be conscious of that, I assure you. Dr. Firdousi Qadri is Emeritus Scientist and Acting Senior Director of the ICDDRB's Infectious Diseases Division. She's sitting in the middle. She is the Adjunct Professor and Research Scientist at the Bangladesh Institute of Health Sciences, previously in the Biotechnology Unit of BRAC University in Bangladesh. She's also headed the ICDDRB's Center for Vaccine Scientists and as head of the immunology section as well. Earlier, she was a senior associate in the Department of International Health at the Bloomberg School of Public Health at Johns Hopkins University. She started her academic career in the Department of Biochemistry at the University of Dhaka. Mr. Fred Binka, on your left, is a professor of clinical epidemiology and the Foundation Vice Chancellor at the University of Health and Allied Sciences in Ho, Ghana. Previously, he was Dean of the School of Public Health at the University of Ghana. He holds a Bachelor of Medicine, Bachelor of Surgery, Masters of Public Health with distinction from the Hebrew University of Jerusalem, and a Doctor of Philosophy and Epidemiology from Basel, Switzerland. He worked with the Ghana Ministry of Hebath for 20 years and has served on the World Health Organization's Malaria Policy Advisory Committee. He was the first recipient of the Rudolf Geige Award in 2001 from the Geige Foundation in Basel, and he received the Ronald Ross Medal in 2010 from the London School of Hygiene and Tropical Medicine for his work on malaria. Dr. Roger Glass, closest to me, is the director of the Fogarty International Center and Associate Director for International Research at the U.S. National Institutes of Health. In 1977, he joined the Centers for Disease Control and Prevention, the CDC, as a medical officer assigned to the Environmental Hazards Branch. He was a scientist at ICDDRB from 1979 to 1983. In 1986, he returned to the CDC to become chief of the Viral Gastroenteritis Unit at the National Center for Infectious Diseases. He's earned numerous awards, including a Lifetime Scientific Achievement Award from the CDC, the Merio Award from the National Foundation for Infectious Diseases for his work on rotavirus vaccines in the developing world, and in 2015, the Sabin Gold Medal Award for his contributions to improving children's health worldwide, including novel scientific research for the prevention of gastroenteritis from rotaviruses and noroviruses. So I'm going to step over now. We don't have unlimited time. Dr. Clemens, I felt covered quite well. The first question I was going to ask you is, okay, the cholera formula is your big hit. That was your breakthrough hit in the top 40 list. What's on side B? But I don't think we need to do that. We've heard a lot of the side B efforts which are succeeding as singles of their own, if you will, to continue the metaphor from the top 40 list. But what I would like to explore with you, and Dr. Qadri, I'm going to ask you first, you've been at ICDDRB for a long time. I think you started when you were a young one and presumably in a situation where you had mentors at the organization. What is it about the culture of ICDDRB, the place where you work on a day in and day out basis? What is it about the culture that seems to have enabled and empowered, if you will, so many young scientists, researchers, and practitioners to achieve the kind of success this organization has achieved, and of course you yourself personally?
So you've asked my favorite statement that I make to the world every time, to my younger people and my colleagues. It's
can you hear? Can everybody hear?
Can you?
Yeah. Okay.
So when when I drive into ICDDRB every day.
Would you mind holding that up? It'll probably.
So when I drive into ICDDRB every day for the last 25 or more years, the most important thing is that you live in a developing country, but when you enter into ICDDRB, it's the atmosphere that makes you do everything that you want to do. So you have the problems of Bangladesh and the developing world, but you also have the infrastructure of ICDDRB that helps you deal with these problems. So being a scientist working in the laboratory, I've been able to do things that I wouldn't have been able to do anywhere else in my country and any other developing country, and I can use the state-of-the-art facilities which has been developing over the last 25 years, and we have the best in the laboratories, we have the field sites, and we have the atmosphere of complete dedication. And we are reminded by our executive director and the board all the time that we have to do work that has impact on the life of people that we live with. So that makes me work, and that makes a difference.
Is the fact that you're working, because you mentioned this yourself, is the fact that you've been working in a situation where the people who can benefit from your research are in effect outside the door, or just outside the door of your laboratory?
Yeah.
Has that enabled a kind of speeding up of the process of research so that you can see results, turn them around quickly and say, no, this is not working, let's tweak it this way? Is having that real world environment right outside your door a key to the success?
So when you're working in an atmosphere where they're not outside the door, the hospital is downstairs, so you cannot forget about the problems. Take cholera, for instance. We have 20,000 patients coming to the ICDRB hospital. Twice a year they come in epidemics, and once more if there is some kind of a flood or a cyclone or something. So it's there perpetually, always. And there's nothing that can be done except very good treatment that we have, that ICDRB has helped benefit the whole country and the world, but also there are prevention methods. And so you cannot forget it. You have to work hard, work quickly, and that's how we've been developing the cholera vaccine. I'm just talking about one disease, but there are many others. And that's how the easily available, affordable vaccine is now being used in the Rohingya refugees. And so you cannot forget what your problems are.
Okay.
You live there.
Well, I want to follow up with another question, but I'm not sure which of you is going to be best equipped to answer this. Something that struck me about ICDDRB is the combination of the research laboratory and the, I'm going to say, manufacturing function, which really is not, I think, very common in this field, where you you find a solution, and then in the same place and among the same people, you figure out, how can we do this cheaper? How can we get it out the door faster? How can we move it to the places it's needed most quickly and most effectively? That's a different thing than just empowering researchers to do the medical research. Now you need to empower other kinds of people to do this other aspect of the work. Dr. Glass, maybe? Is that something that you can comment on?
Sure. First, I spent 4 years. Is this on?
I'm not sure.
Not sure. I spent almost 4 years in Bangladesh, and I saw knowledge being turned into action. When I went there were very few pathogens that were known. Now there are many. And so it's taking each of these and understanding them to turn them into programs for vaccines or interventions, and the implementation of strategies. The development of zinc as a supplement for diarrheal disease treatment was really worked out in Bangladesh. John was mentioning about malnutrition. That was a chronic problem throughout the world, the link between malnutrition and diarrhea. And the lovely photo that John showed is a way to work out a strategy, work out methods to improve child health, work out a cheap solution, because in a country like Bangladesh, only inexpensive solutions that can be brought to scale will be impactful. I've worked on rotavirus vaccines in the United States, and the price of the vaccine is $200 a child for a disease that's so common. It's the #1 cause of diarrhea in Bangladesh. We couldn't do that. And so we've worked now in India to make $1 a dose vaccine, something that can be brought to scale. And this is being tested now, and it will be tested in Bangladesh, and it'll be the vaccine that Bangladesh uses. So the idea of having cheap solutions is something that's absolutely essential, and Bangladesh and ICDDRB have been on the forefront of this. The CPAP is another example, and to see that scaled up now for the prevention of neonatal deaths would be a huge improvement in child survival in the future. It's an amazing place. You're right there with the diseases, and this is where you have to take science where the problems are.
Mr. Binka, maybe I could bring you in on this one. Another thing that struck me about ICDDRB's contribution is, of course, it has achieved what it has in the medical research field, and it has also achieved what we've been talking about now in the distribution and scaling up phase. But a third characteristic of ICDDRB is that it has had a great influence on policy, healthcare policy, both in Bangladesh and in other parts of the world. Is this a model, do you think, that could be adopted by other organizations where they not only develop the solutions, figure out the manufacturing part, but also can make strong policy recommendations which political officials, elected officials can both understand and implement?
Yes. So first of all, let me thank the Hilton Foundation for inviting me, and congratulations to colleagues in Bangladesh. Truly, the team has demonstrated 3 other ways in which you could influence policy, and directly from my own experience. Professor Clemens talked about the longest running demographic surveillance system in Bangladesh. We went to Bangladesh and we were exposed to this demographic surveillance system, and we've translated it back into Africa, and 20 countries are running what we call the HRS, trying to look at demographic surveillance. Maybe you don't appreciate what a demographic surveillance is, but over 1 billion people, children who are born in the world are never registered anywhere. So these systems help us to be able to measure the impact of these interventions, and the MATLAB demographic surveillance system has been a great example. Secondly, we've also had the chance to look at the community health workers that he talked about. And yes, you have community health workers everywhere, but Bangladesh had a policy or a strategy that took the services to the doorsteps of the community. So that made a lot of difference in trying to provide preventive and promotive care in addition to treating minor ailments. We translated this in Ghana into what today in Ghana is called the CHIPS program, and we've had exposure to other countries like Ethiopia, Burkina Faso, Sierra Leone, and Nigeria. So these are other policy directives that the Bangladeshi team has actually developed that is influencing healthcare delivery in other parts of the world, not to talk about the products like the vaccines and the ORT that we've heard about.
Are those examples of South-South collaboration or cooperation and proliferation of these programs that?
Yes, definitely. This is a strong South-South connection. We've had to visit, and we find the environment in Bangladesh quite similar to other parts of our own countries. And so adapting some of the things they've developed there has not been very difficult. And that has been very, very helpful.
All right, now I want to ask a question that may seem initially as if it's a bit snide. It's not intended to be that way, but following up on the policy aspect that we've just been talking about, Dr. Clemens made reference to Professor Piatt's global health eras, and I think he had a little smirk in his voice as he was doing that, version 1.0, 2.0, 3.0, 4.0. Is it impossible to imagine that global health era 5.0 might be the one in which researchers and policymakers in poor countries, such as the ones in which you work, lead policymakers and researchers in rich countries? Is that something that we might imagine and maybe even get to the point where universal health coverage, which you clearly do work on, is something that might come to rich countries that don't have it? At least they're all smiling, so let's see where we go. Dr. Glass, do you want to handle that one?
Absolutely. Absolutely. You know, they say necessity is the mother of invention. If we want to have really expensive solutions to today's health problems, we should do it right here at home. But if we want to have ways that are economical, can reach everyone throughout the world, if that's our global market, then Bangladesh is a great place to start. And the oral therapy for pennies a dose is an example of that. The use of zinc for supplementation is another. The use of community health workers to go door by door. If we could use those community health workers to deal with our problems of TB in the United States, our problems of HIV adherence to treatment, we could learn a lot from these systems. So I think Bangladesh, and technology, simple solutions to CPAP, an incubator, a cheap incubator that could be used in small facilities, great idea. That innovation is really going to come from places like Bangladesh. And training people in these collaborations are absolutely essential. So I think 5.0 is not a bad place to go. So I think there's a lot to be learned from this, and that'll be the next step.
Dr. Kadri, do you ever, I imagine that you travel frequently from Bangladesh to many of the places where the work is being done, but also here to the United States. Do you ever sit in your lab sometimes at the end of the day in Bangladesh and say, I can't understand why the United States isn't interested in this. We showed them this, why don't they do this? Does that ever, kind of thought ever cross your mind? And how do you approach policymakers and physicians like yourself here and say, well, why don't you just pick up on this?
I mean, one of the reasons probably is that, you know, if you don't have that health problem or that problem in your country, you know, don't think about it. So I can go back to the case of the cholera vaccine. When John started working on it in the 80s, and we had one cholera vaccine. I think, Roger, you also worked on it. And so we had a vaccine for many years, which was $32 a dose. The developing country people did not use it, could not use it until John again went and started working to make it affordable. And then now it's becoming more and more affordable. So I think that's the reason. If you don't have the problem, you don't think about it. I think that's the major. So you have to think about the South and the problems of the South, and also think that you may have that problem here in the United States again one day, which I'm seeing many diseases are emerging. Yeah.
Some of the technologies, though, the scaling up technologies, are the kinds of things that ought to be able to be applied to problems that are different problems, but nonetheless usable by a first world country.
But even scaling up is, I think, becoming cheaper in developing countries. As I can see, the vaccine technology is becoming cheaper in India, and soon in Bangladesh. We have, ICDDRB has now started working with companies and making this transfer of technology for cholera vaccine, for HIV vaccine, for other vaccines. So I think maybe we will be directing much more. Okay,
5.0, we'll get there. Dr. Binga, did you want to comment on this subject at all?
Yes, we definitely are at 5.0 already. The world is now a global place, and there are many of the problems you have in the first world that has solutions in the third world. And the earlier you start adopting them, the better. One big challenge you are going to face among the SDGs is providing universal health care. And I think we will achieve that earlier than most of the countries in the developed world. So there's something you have to learn from us. So we are there already.
Since we're talking about the Sustainable Development Goals, child mortality and maternal mortality are the ones that ICDDRB has tackled and successfully tackled. Are there others that you think ICDDRB might be tackling in the near future or approaching the near future? Not to say that what you've done isn't enough, you've got to do the next thing, but are you focusing on that aspect of work as well? Going to other sustainable development goals, achieving other sustainable development goals? So, yeah. Well, you did speak about universal health care.
Yes, okay.
No, that's all right.
Yeah, so the universal health care is one. that we all are looking forward to, and we have to find ways in which we can bring this close to everybody and make sure everybody can have access. Secondly, I think there are other solutions that we need to share among the group. The infectious diseases are still there. We're getting new vaccines that have been developed. For example, it's when I come to the United States, I come along with my anti-malarial treatment, because if I get malaria in this country, my chances of dying are very, very high. You might not believe it, but that's true. I always tell my colleagues, take along your anti-malarial treatment, because it will take you a long time to find a physician who is going to treat you adequately if you had malaria. So there's a lot to be learned from both sides. It's now a global world, and we have to work together and to achieve the goals that we are setting for ourselves.
Okay.
I bring my antibiotics with me, just
Sorry?
in case. I bring my antibiotics with me, just in case.
I also think that the curve that John showed of the number of children to a mother that's decreased from 6.5 to 2.3 over the last 2 or 3 decades is absolutely awesome. And that's something that's going to create a demographic dividend in Bangladesh and really change the economics. When I went to Bangladesh, it was Henry Kissinger who said Bangladesh was a basket case. No hope, and look at it today. It's completely changed, and that demographic transition is just is just starting. If you look at China at the same time, they were just as poor in '77, and they've grown up because of that demographic dividend. So I think Bangladesh is in a very interesting spot today that's unique, and ICDDRB is part of that change, has been absolutely instrumental in thinking about issues of fertility, of gender empowerment, and the importance of women and women's education and women's care. So I'm looking forward with great enthusiasm to the next decade or 2 decades, and I hope that this Hilton Prize, which is so well deserved, will help to energize others to look to Bangladesh for some of the solutions to the world's problems and to achieving the SDGs on schedule, just like they did for the SDGs this time.
One of
the MDGs.
One of the things that emerges from this conversation just now seems to me to be, you have in your work a very supportive government. That is to say, it seems to me the government of Bangladesh and ICDDRB literally work hand in hand every day. I'm sure you have no difficulty when you need to reach someone in the government to ask about something, or when they want to reach you about something. There's no, I imagine, no bureaucracy that stands in your way. What are the challenges of working in an environment where that may not necessarily be the case, where you work with another country in Africa or elsewhere in Asia, or maybe even in the developed, highly developed, wealthy world, where government and healthcare institutions are not so closely tied and are not so eager to be cooperative with one another? Are there secrets you can share about how to make this work, how best to make this work?
I think ICDDRB has been very successful in this relationship because they have products and have proved themselves with the last 50 years of service. So we are an international organization, very much nationally oriented in the requirements of the country. So whenever we do anything, our research priority is for Bangladesh. It's not alienated from Bangladesh. I think that's the main thing I see. So maybe other countries have to remember to do that also. And I think we are also based in the government facilities, health facilities. So we have a very close collaboration. I can just give you the example of this, the Rohingya problem that we have of so many people. There are about 500,000, more than 500,000 people now in Bangladesh.
Half of them children, right?
Yeah, 60% children and women. Yeah, and so the way it has happened is this requirement for the vaccine. It was I think the suggestion came from looking at Yemen, what happened in Yemen with the political disturbance. There were so many deaths and over 500,000 cases. And so this was the first time that as a preemptive way of preventing deaths in a country, in Bangladesh, in the refugee population. And so all this happened within 7 days. And it happened because the government and international organization and ICDDRB was with it. So everything, the ICG request and everything went out so quickly, and it was just a collaboration of quick interactions internationally and with the national government. So we now have vaccines, over 90,000 being given every day from yesterday. So we have really proved that the vaccine from the stockpile has never been taken so quickly. The request has not gone in like this. It has only gone in after a disease has stuck. But this is actually really historical, the way it was done. It was because of the relationship with the government.
The preemptive nature
The
of
preemptive nature. So there's not been almost any cases of cholera yet in the population.
And how did you have the manufacturing capability to respond within a week or two the way you have been able to respond?
We do have a manufacturer now that this transfer of technology has taken place, but that vaccine was not ready. It came from the OCV stockpile of the ICG, of the WHO. So it was actually historical. I'm amazed how it happened. The vaccine came by a chartered plane and it's now in that area.
Okay, all right. Remarkable, really, I must say. I was going to ask you a little bit more about the refugee crisis. Are there, aside from the monumental achievement of dealing with the potential for cholera outbreak there, are there other things you are currently learning from this humanitarian crisis on the border that will help you the next time, or perhaps in another country? Any lessons you can immediately say, here's what we have to be ready to do the next time?
I mean, it's a political problem, you cannot do anything about it, but I mean,
Why
I don't
not?
think.
Why not?
I mean, there were many speakers here talking about all the issues in the world, but I think we've set a good example. The way that it's a matter of feeling. I heard something very nice over here. It's when there's a refugee influx, it's the heart that brings you in, brings the people, and it's happened like that in Bangladesh. Nobody is complaining that there's so much attention on the refugees and not on the general population. It's a matter of just giving now. I think we've learned that even being a reasonably poor country, although we are low middle income now, we can do a lot to help. It's our power that we've felt in this situation has been magnificent. And what we've learned is the sharing between all the international organizations at Cox's Bazar with the government and with ICDDRB actually being very top of all these activities. And so we can do, there's a lot of maternal health and child and maternal health work, even work on tuberculosis, HIV/AIDS, nutrition, and treatment. All the treatment that ICDDRB has, we've set up treatment camps over there. And so we've learned that we can work in an emergency of this magnitude.
This may seem like a little bit of an obvious question, but maybe Mr. Binka can best address this. ICDDRB has been around, obviously, for 5 or 6 decades, and so the reputation is there when ICDDRB speaks. Mm-hmm. People listen, they say, you know how to do it, we're at least going to listen to you. Can other organizations that don't have that long reputation, are there ways they can skip ahead, establish the credibility that you have established over time, so that when crises develop, they will be listened to more immediately, responded to more favorably, and solutions will get into the hands of the people who need them more promptly?
Yes, I think there's a lot to be learned from a situation like this. In fact, for the Rohingya problem, from where I sit, the biggest problem that is really going to face both Bangladesh and the Rohingya people are the malaria-resistant parasites. Myanmar is in the region in the Sub-Mekong region, where the resistance to anti-malaria drugs is very high. So these people have moved from an area where there's resistance to anti-malaria drugs into Bangladesh, where this is not yet a problem. So if that is not monitored very well, we are going to see drug-resistant malaria within the borders of Bangladesh, and that will be a bigger problem. But clearly, I think the major issue is that we have to learn from the experiences from other places in the world. And obviously, what Bangladesh has done so far, I think from where I sit, even in Ghana, people are really appreciative of the speed at which they have try to help these people who are in need. And I'm sure recent problems that have faced us on the continent, the global pandemics, are making countries a little bit more prepared to receive people in such situations. But there's still a lot to be learned from countries like Bangladesh and what they've achieved so far.
Did either of you want to comment on that aspect? Because I'm going to ask.
I can just talk about, the children young children coming from Myanmar have never been immunized. So that's a major problem for Bangladesh, because we have almost 90% immunization coverage, and also with the polio vaccine. And now we have children coming into Bangladesh who have not been immunized.
Are you dealing with that?
Yes, so 100,000 children, 1 to 5 have been given polio vaccine and the MR, measles rubella vaccine, but others, after the OCV vaccination, the others will continue. Okay. It's been a massive task.
I have a last question, and we're almost out of time, but I would like to just ask this. It's kind of a different perspective. You are, if I will say, a shining example in a lot of areas. We've talked about the political one already. What about for young researchers, and I'm thinking of doctors like Dr. Murabit and others who are growing up in other areas of the world, perhaps even in the rich countries of the world. Do you have a message for them about where they can go to learn what they need to learn, practice what they need to practice in a situation where their work will make an immediate difference? Is there an invitation or something that you could set up, or as an example that ICDDRB might be able to set up for those young people looking for places to be most effective in their young lives?
If you're a banker, you want to go to New York to learn how to be a banker. And if you're into fashion, you probably go to Paris. But I think for infectious disease and diarrheal disease and childhood infections and vaccinations and nutrition, the place to go is Bangladesh. And if you look at and we at Fogarty have sent many young people to Bangladesh for specifically the reason that they can learn so much and get grabbed by the ideas, the problems that are there, and the ability to seek solutions on the ground. The laboratories are outstanding. The field sites are so well organized that you can go back and not only find the parents of children, but the grandparents of children, and look at data that you couldn't find in the United States. So it's a huge training opportunity. If you look at the young John Clemens of 3 decades ago, he wasn't a cholera guru or a diarrhea guru. He went and he learned, and he got grabbed by the topic. And here he is 20 some years later, back as a director, because I think the problems of Bangladesh are so compelling. There's so many Americans who have been trained by experience in Bangladesh that's redirected their careers. My wife and I are among them, but there are many, there are dozens, and there are dozens from around the world. Furthermore, the fact that John showed that map of the world, of all those developing countries where Bangladesh and ICDDRB have sent teams to help, the best teams to train others on cholera treatment are the teams from ICDDRB, and people from those countries have come back to Bangladesh to learn how to do it and to do the research that's needed. So it's a global resource for the world, and it's a model for networking South-South collaborations with an Institute of Excellence in child survival issues and enteric infections, respiratory infections, and neonatal prevention of neonatal mortality. It's an outstanding place, and I think I'm so delighted that the Hilton Foundation provided this extraordinary gift and recognition to ICDDRB for its many years of contribution. It's made such an impact in the world and improved the health of not only Bangladeshis, but those internationally in low-income countries. It's a real center of excellence. Thank you.
So, Roger has said it all, but this is also our frustration in the South. It's so difficult for me to send somebody from Ghana to Bangladesh. We are not supported to do that. Our governments don't send people to other parts of the South to learn what is there. It's easier to come to America or to go to the UK, but it's tough to go to Bangladesh, and this trend must stop. we need to learn from those environments, because those environments are similar to our own environments that will help us to achieve these goals much quicker. Thank you.
Thank you. I'm afraid we're out of time. I want to ask you to thank our guests, Dr. Roger Glass, Firdausi Qadri, and Fred Binka. These are the heroes. You met John earlier, but these are the heroes who are doing the kind of work that the Hilton Prize rewards.